different objectives to create predictable objectives. Okay, so we have guests, doctors from Bucharest. We have doctors from Poland, Spain, India, Sweden, Malaysia, Albania, Morocco, Yemen, India. Yeah, doctors from France, from Manila, from Rizal, from Iraq, from Serbia, from Agusan del Norte, from Tayabas, Belgrade, Portugal, Cambodia, Netherlands, Pampanga, Botswana, Qatar, from Quezon City, from Romania, from Myanmar, from Turkey, Germany, Dasmariñas, Cavite, and I think it's all coming in. Good evening, everyone. It's good to have you with us tonight, today, for this webinar. So I'm gonna go shift slides. So before we go on to the main topic, we're going to have two more webinars this week. The first one will be this Saturday morning, 10 a.m. It's the second episode of the COVID-19 dental FAQs with Dr. Jetpo and Dr. RJ Dula. It's going to be moderated with Dr. Paulo Manzano. We've got interesting questions last Saturday, and we hope you guys join us again for another loaded session on Saturday. And following on Saturday as well, at 7 p.m. in the evening, Manila Standard Time, we're going to have episode 4 of Botched. Uh, this is this is with Dr. Pau and Dr. Adid Venogopal. They will discuss more interesting cases for you. So you join hope you join them. Okay, so I think we're ready to start. So little disclaimer before we go on. Bio and any of its speakers and guest speakers have no financial interests and arrangements or affiliations with any product or company which could be perceived as having real or apparent conflict of interest in the context of the subject of any of our webinars or lectures. All our speakers and guest speakers are not accepting any honorarium fees or gifts and are selflessly voluntary. All published webinars are free and are used only to help dentists cope with the pandemic and quality science-based webinars. So let me add on to this, and playbacks are available. This lecture is going to be available in playback. Botched episode 2, botched episode 3, as well as the first episode of COVID-19 seminar is all available in playback. You just have to go to bio bioorthodontics Facebook page, and you just have to follow the thread. All right, so let's start. So this topic is something that is it's really captured my interest and it's really close to me. And this one is making the most predictable treatment outcomes. We have a lot of dental parameters that is available now in the market, and I will uh, I will focus on this one parameter that will be very useful for you guys if you want to have a good diagnosis and a predictable treatment plan. So let me start off with a question. What makes a predictable treatment outcome? Right? So a predictable treatment outcome for you and for me is it's a good diagnosis that is coupled by a good treatment delivery. And sometimes we have cases that puts us in the crossroads. In diagnosis, something is unclear on when we are reviewing our diagnostic parameters. Something is quite unclear, and it gives us a very blurred diagnosis, sometimes a very blurred objectives and a blurred plan as well. Let me just pause for a while, check this. Okay, check the stream. So let me check first my stream. I'm having a little difficulty with the stream, so let me check it for a while. Sorry. Okay, so I can continue. For a while, I have to check this. Sorry, everyone. I'm checking the signal of the stream so that we can get the best reception for this lecture. Okay. Dito sa ano, yung iPad.
Wala internet?
Hindi, yung iPad yung iPad walang ano.
Ito.
Hmm?
Ito, meron ba?
Hindi, chinecheck ko yung stream.
Meron naman. Kasi nag-call.
Okay lang. Okay, so I think we can continue now. Good. Sorry for that little glitch. And sometimes crossroads in diagnosis will give us a misdiagnosis because when we're diagnosing cases, we are unsure. There are some blurred parts of it, and it turns out sometimes we misdiagnose. When we misdiagnose, it could spell disaster in our treatment plan and delivery, and can give us major problems in treatment. So I'm going to share to you some of my cases that put me on the crossroads, and how did we find solutions on these cases. So right here. So the first case is this one. So this patient is originally an orthodontic case, and as part of our comprehensive treatment plan, removal of the third molar should be done. And as you can see here, we have a panoramic, which is a standard protocol if we are to diagnose our impacted third molars. And if we're going to diagnose this one, we're going to start off with the horizontal 4/8. So we can clearly see that the 4/8 is horizontal, but we still need to establish the relationship of the nerve in relation to the tooth, as well as how many roots are there on the third molar, because that would spell the difficulty as well the complexity of the case. Now, panoramic radiographs are quite limited to this aspect because of the superimpositions among the roots and the tooth to the nerve. And if we are not experienced enough to spot these, we will always have doubts in our approach when we discuss our plans to our patients and even during surgery. So, with the relationship of the nerve, we have here two aspects that could superimpose. We have your third molars, and of course, your nerve. And we are unsure, just by looking at the 2D radiograph, if we are not experienced enough, or if we have doubts on the position of your nerve in relation to your tooth, we are unsure if this nerve is placed on the buccal of the tooth, or it could be on the lingual. Worst case scenario, it could be dead on the middle. So with these things that we have to consider, plus the number of roots available on these third molars, we are put on a diagnostic crossroads. Um, Different positions of the nerve, of course, we have different management for each. We have different levels of care when we try to manage this one. And it could blur our treatment predictability. So let's look up the upper. The upper third molar is, we always ask this question, is it approximating the sinus and the number of roots? And then looking at this 2D radiograph right here, we can just see that it's approximating the sinus, but we are unsure of the number of roots. And it appears in this 2D radiograph, it appears to have roots that are separated, or just two roots. So in the sinus approximation here, we know it approximates the sinus, but we want to know how close, right? So this in this aspect, in this third molar diagnosis, when we create our treatment plans, when we discuss to our patients, sometimes we have this situation where we have a blurred diagnosis that gives us a blurred predictability, right? So, and here's another case. So in this case, the RCT is done on tooth number 16. The first complaint was there was pain on tooth 16, so endodontic treatment was done. However, just a few days after this orthodontic treatment, in this endodontic treatment, the patient returned to the clinic complaining of tenderness on that same area. So we did diagnosis on this part, and turns out that 17 was positive to percussion. And of course, just by looking at the 2D radiograph and just by looking at it clinically without obvious signs, without obvious indicators, we are puzzled, or we have a blurred visibility on what could have caused the pain for this tooth. And we are now in the context of crossroads. We are now in the crossroads in identifying the real reason of the pain. It happens once in a while. And speaking of once in a while, sometimes we have these kinds of patients that we encounter that their chief complaints say they have an unerupted tooth number 21. And when we check clinically, the patient was 10 years old during this consultation. She was bullied at school because of her front teeth, and this unerupted incisor definitely made an impact to lower her self-esteem. So this young, 10 years old, being bullied at school because of that unerupted 2-1 that retained 6-1. And upon consultation and check-up and assessment of the panoramic X-ray, we initially proposed a surgical orthodontic management solution. However, since the patient and the parents, they are looking for a quick solution so that the bullying will stop. That's the urgency right there. And of course, this situation is where my hands are held behind my back, and it really challenged me to look for a quick solution. And this one, with all the compromises, with all the discussions that we did to our patient, we finally agreed to do our best to have cosmetic restoration on tooth number 6-1. So we will do cosmetic restoration, make it look like tooth number 1-1, and when the time comes, the patient has the confidence to undergo surgery and ortho. That's the time we will manage it in the ideal way we want. So unfortunately, this treatment did not push through because the patient went to a long vacation in her province, and it took her a year to return. So when she returned to our clinic, they told upon interview, while they were in vacation, they went to another practice, and they opted for the extraction of 6-1, hoping that 2-1 will erupt. And in this situation, she is bullied even more because 6-1 is gone. She has a gap there in the anterior segment, and her self-esteem is at an all-time low. And they return to our clinic and they opt for an orthosurgical solution that I've proposed to her. So they now opted to the initial treatment plan that we suggested to her in the first visit. And by looking at this panoramic radiograph, there is a mass that obstruct the eruption of our 221, and I believe the dentist who did the extraction might have been on that crossroads when she managed this patient. So that could have blurred the predictability, and now the 2-1 cannot erupt because of this obstruction right here. So we need to do management. So we don't want that to happen in our case. We want to have a very predictable outcome so that the level of confidence of our patients in our practice and our confidence to our treatment will be improved or will be good. So those are the crossroads in diagnosis. And the crossroads in diagnosis will definitely lead us to a very blurred treatment outcome, which means the predictability of our outcome is not that good. It's very blurred. We are not sure. And what if there is a way for us to have a clarity in diagnosis where we can see, where we can have a predictable outcome, and one way, and the way we can do it is to have a parameter that is clear and that can satisfy our diagnostic objective, and when we view our case in a different perspective. So let's go to the main topic. So we talk about virtual reality. So your virtual reality means, by definition, it's a computer-generated simulation of a three-dimensional image or environment that can be interacted in a seemingly real or physical way by a person using special electronic equipment. I want you guys to focus three on three terms right here. We have your computer, three-dimensional image, and can be interacted. I think in terms of dentistry, it now starts to ring a bell. So when we say virtual reality in dentistry, which is computer-aided approach, processed in a three-dimensional image, and we can interact with it, of course, this is going to be our cone beam CT scan. And our cone beam CT scan, this is a current advancement in dentistry that allows us to view our cases in a different perspective. So let's have a quick poll. And I just want to know how familiar is everyone with the applications of the CBCT. So I'm going to launch the poll now, and I'm going to wait for your answers right here. So if you have any questions, you can post it down below on the comment sections, and we'll address it on some parts of the lecture. So the poll is now out. Okay, I published the poll. So I just want to know how familiar are you with the applications of the CBCT. So yeah, so we have unfamiliar. We have some guests that are unfamiliar, some guests that are quite familiar. Oh, now we're getting some of those who use CBCTs, but they don't know how to manipulate it, and some people use CBCT and they don't know how to manipulate. But yeah, so majority are in the zone of dentists who are quite familiar with the applications of the CBCT, and this lecture is for you. Okay, so this lecture is for you. I'm going to show you how are we going to apply cone beam CT scan to address some limitations in our diagnosis, so that we can see all those blurred areas in our diagnosis. Okay, so it's good that we have guests, we have doctors who use CBCTs and knows how to manipulate. It's good to see. Okay, so I'm going to go back to the slides. Okay, so let's talk about the evidences on accuracy of your cone beam CT scan. So there were two studies that concludes or that suggests that CBCT is reliable for linear measurement of structures closely associated with dentomaxillofacial imaging. So we have here studies by Dr. Kobayashi and Dr. Lascala. So I'm going to give you some details on that. And the study by Dr. Lascala is when they measured some points, specific points of the skull of a dry skull, and then they took a CBCT of that, and then they measured it again. So on this first table, these are the points that they use as reference for the measurements. And this is one part of it. They use the lateral orbit as a landmark, and the results are quite amazing. Uh, their conclusion is that although CBCT images, CBCT images underestimates, meaning they have a measurement that is relatively shorter than the real subject, differences are only significant for the skull base. For the skull base. But when it comes to the dental and maxillofacial region, it has a good, it's very close in the linear measurements. Okay? So here's another study by Dr. Kobayashi. This time they used the mandible, they drilled holes on it, and they took a scan and then they measured. And they got the same conclusion. It's reliable for linear measurements. When they measure the holes, compare the holes, they have almost the same results with Dr. Lascala. CBCTs, though, measure it relatively a little short, around 2 millimeters short, but the discrepancy is more evident on the cranial on the base on the skull rather than the dentomaxillofacial region. So with these findings, the earliest applications of CBCT in dentistry is this one: linear measurements of pathological lesions of the maxilla and linear measurements in implant planning. So those were the first applications of the CBCTs. And with continuous advancement of this technology, it allows us to apply this imaging technique in more fields of dentistry that I will show to you later on. All those cases before that I've shown you, we'll look for solutions there through the CBCT. So the next issue here is the next evidence on accuracy is the lower the voxel size, the better the image quality, thus the higher the accuracy. So this came from the same study by Dr. Lascala, and it's supported by studies by Sun. And let's talk about voxel first, so that we can get the full description of this segment. So your voxels, they are the basic unit of your 3D images, and your 2D your 2D uses pixels as their basic unit. So how are they different? So here is a superimposition of your CBCTs and your panoramic X-ray. So you can see your panoramic X-ray follows your CBCTs, right? And when we split them up, pixels they are all registered on a flat surface because they deal with two-dimensional images. They all deal with the flat surface. While in 3D, since we use voxels here, your voxels, they can go to the depths of the target. They can capture the details as well as the orientations and the depth of the subject. Okay. And when we speak of voxel size, the smaller it is, the higher the accuracy. So when this study was done by 2004, the available voxel size of your CBCT machines were just 0.2, 0.3 to 0.4 millimeters. And when you decrease the voxel size, compare your 0.4 to 0.2, you can see significant difference in terms of the image quality. And if you have good image quality, of course, it can give us more accuracy. And currently, there is with the advancement of this technology, voxel sizes tend to go smaller. So we have now the most common in the market is around 0.076 millimeters, and there are CBCT machines that can give you a lower voxel size. So you can see the difference now between your 0.2 millimeter voxel size and your 0.076 millimeters. You can see how much surfaces got crisp details, got good image quality, right? And so when you check your CBCT provider, say you want to send your patients for a CBCT scan, it's okay if you will ask how much is their voxel size, because the voxel size will determine how good will be the quality of your image. Remember, the smaller the voxel size, the better the image quality. It will give you the higher accuracy. Okay. So with this advancement, it now allows us to go deeper to the to assessment in our dental structures. So this is a scan in a 0.076 millimeter voxel size, or 76 micron voxel size, and this is the region of the floor of your cavity. So when we're doing endo, right, we do access preparations. So that's where we locate the orifices. So to make our treatments more predictable, by seeing our CBCT scans here, we have we can already see in this area that we have 3 orifices. We have 3 orifices, and for us to be sure, we can scan down. And as we scan down, it gives us 3 canals. Meaning, if we perform biomechanical preparations and obturations on this case, we won't have second guesses of the existence of a 4th canal, because according to your CBCTs, and with that small voxel size, gave you 3 canals already. Okay, so this is the good advancement of your CBCTs, meaning we are now moving forward from the limited applications of your CBCTs in implant and in complex surgery. So we can almost use it routinely. We can use it in cases where we need an accurate view, or a very clear view of the objective that we want to see. So your CBCTs, they are always rendered in DICOM by default. So when you ask your suppliers, or when you ask your service center or your diagnostic center or your clinic, this is the default format. Since we need the computer to manipulate it, we need DICOM to be the format. And your DICOM means it's digital imaging and communications in medicine. So this format is universal, meaning if you send it to me from the Philippines, provided it's DICOM format, I can open it and I can send you that file wherever you are in the world. So this is one crucial information that we need to understand when we're dealing with CBCTs, the format. We want it universal. We want it the advantage of this technology is that we can communicate with our colleagues, not just near our practice, but even if they're miles away from us, we can still do consultations. We can still do discussions. And your DICOM format should be opened on an open source DICOM viewer software. So some manufacturers, they render their CBCT files according to their preferences, like on how they prefer their interface to be manipulated. But I like to show you the basic perspectives or views present on every CBCT programs or every CBCT softwares that is sufficient for everyone to effectively diagnose your cases and make treatment outcomes predictable. So let's go to your perspectives. So we have your first perspective. The first perspective, since it's three-dimensional, so we are expecting three basic perspectives. The first perspective is your sagittal that moves your scan from left to right. Again, sagittal moves your scan from left to right. Okay, so if you're going to visualize a sagittal view, it seems like you are looking at your patient on the side view. Okay, that's sagittal, left to right. The second perspective is coronal. Coronal moves from anterior to posterior, front to back. Okay, so with this one right here, it seems like we are viewing our patient anteriorly or posteriorly. So if you can look at this one, it's like we chopped the face on the coronal aspect, so we can see these kinds of images. And the third perspective, to make it three-dimensional, is your axial view. Your axial view moves from superior to inferior. So with this one, it allows you to view your case just like you're viewing your occlusal aspect of your cases. So we have now the three basic perspectives: the sagittal, the coronal, the axial. So here's what's fun. Because this three basic perspectives is present on software A. Of course, you can add the 3D view here so that you can have a visualization on how you orient your cases on something to relate to when you're doing your manipulation. And here is software 2, shows you the three basic planes and the 3D and the 3 different view as well, and the 3D view as well. And here's another software which shows you the same. And here's another software that shows the same. So regardless of what CBCT software you are handling, these three planes, these three basic perspectives should be present when you try to manipulate it. Okay, so let's check if you have any questions. I would like to know if you have any questions. Let's check if we have if you have questions. So okay, someone did PM me of a question. Okay, the question was how will I know if the software I am handling can open a DICOM format software? So you have to search for we have to look for software that is an open source. So there are a lot that you can download free. So a free software could be this one. It's called Blue Sky Bio. You can download this one. This is a treatment planning software, but you can view your CBCT scans on it. Another one is Mango. Mango is a software that allows you to view any DICOM files, even medical CTs. However, it's a little limited for the 3D view. In Mango, the only available perspectives are only these three. Another one that I can suggest is also Synedra. Synedra is a good open source software. It gives you the three basic planes and the 3D view, and its manipulation is quite easy. However, it's only available for Windows. And the last one is the one for Microsoft. The one with the tablets. There is a downloadable DICOM viewer on Microsoft tablets that allows you to manipulate the CBCT scans with the use of your fingertips. It's very amazing. It's very good. However, it's only exclusive to Microsoft users. So okay. So what is available for Mac? Blue Sky Bio, I can recommend you guys to download Blue Sky Bio. It has updates for the Mac, but as of now, they are prioritizing. I think they're prioritizing the Windows the Windows version more. But I think updates for the Mac version is on their way. So those are the open source softwares. So you can request any DICOM file from any service center. You just need an open source software to open those DICOM files. Thank you for the questions. So let's continue. So the following slides is on how we can use the CBCTs to have a predictable outcome. So I'm going to show you how do we look for the objectives. So again, remember this case earlier where we initially proposed a restoration of the tooth to one, but it didn't carry out, and the patient came back with this manifestation. And by default, following the two-dimensional perspectives, what we can request is a panoramic and an occlusal radiograph. That way, we can localize the location of your tooth number 21 and your odontoma. So when we look at these scans now, we can see where our tooth number 21, and we can see where is our tooth 21. It's situated on the lingual aspect, but we cannot see the odontoma. But personally, I am not convinced with the objectives that I am setting for an occlusal radiograph. For me, occlusal radiographs are a little limited, and what I can really suggest is have a CBCT taken. So this is a CBCT of the same case. This is the panoramic view of it, and you can see now the position of your tooth number 21, and you can see this mass here, and it seems like it's an odontoma. So we need to have a closer look for us to confirm, or actually the best way to confirm an odontoma is during surgery when you remove it. So let's give the most probable diagnosis for this. So remember the occlusal radiograph. The occlusal radiograph says that my tooth 21 was situated on the palatal. If I followed through with that finding, with that diagnosis, I could have screwed up. I could have accessed it in the palatal. And by looking at the CBCT, it seems it's more convenient to view it on the labial, right? So again, this the previous suggestion still gives me a little blur, and I will opt for a CBCT. So we have now a good vision of your odontoma right here. You have a good vision of your odontoma, and it clearly interferes with the eruption of your tooth number 21. So let's take a closer look. Some dentists, some clinicians, they are having a hard. They don't request CBCTs even if they need one, because they don't know how to manipulate. Okay, they don't know how to manipulate the software. They don't know how to manipulate. And I have once been there. I know CBCTs, but I don't request CBCTs because I don't know how to manipulate. And in the Philippines, it costs quite a lot. So when I learned CBCT, when I learned how to use CBCTs, it really changed the way I see cases. So I'm going to show you how I isolate. So this one. Here's how I isolate my odontoma. So here's the software. I start first with the eggshell. I locate it first, since it's in the maxilla. I locate it upwards. Now I see the odontoma. I just redirect the lines, and then I reorient it to a constructed long axis. So you can see here that I can isolate, and I'm moving the sagittal slice around just to see if there are any borders, or if there are any structures that I am missing out. And so far, this one, with this radiographic appearance, it could suggest that it's really an odontoma. So here's good isolation of the case. And speak of densities now. So this is a 3D view. So what's good with your CBCTs is it allows you to have these filters that can give you a relative density, a subjective view of your bone density. So this one here, since I can see the structure that I am looking for, it can suggest that I might have a very thin bone covering this area. So I checked it in the detail. So this is the sagittal view. So again, it seems like we are looking the odontoma from the side, and this is the coronal view. It seems like we are looking the odontoma up front. So we can see here that landmarks. So this is a cortical segment of your bone. And this one, the darker, the more lucent area is your trabecular bone or your spongy bone. And if we will relate it on the labial aspect, what we can see here that there is no bone or very thin bone covering my odontoma. So we can now relate it to my 3D scan, and it can suggest this one. So why do I make sure that this one will be correlated to this one? Because some CBCT scans, they tend to produce noise, just like this one here. They tend to produce noise, and these noise, they tend to make the scan a little bit dirty and a little bit ugly. So the radiologists, they tend to clean it up, and when they fail to clean it up, what they do is they just manipulate the density. So if if the actual density was altered, this will not become accurate. That's why we should rely on this one to confirm what we see on this aspect. Okay. So now we isolate. Sorry. So this is now during the surgery. So what you see here is the odontoma itself. Again, your CBCTs, there is a thin or no bone, because studies have shown that your CBCTs cannot fully register very thin layer of bone. Okay. However, in terms of managing it, very thin layer of bone doesn't pose big a big disadvantage when we're treating it, because just like in this one, since it has a very thin bone and this is the mold periosteal elevator, the odontoma, when they removed the bone covering that one, they just used the mold. They removed it very easily. So this is what we see in the CBCT. This is what our surgeon sees. So we are not second guessing. We are sure that this area is thin. So it's okay. It's easy. It's easy to remove. So now let's go to the during the surgery, if I may go back, I would like to share to you. During the surgery, the surgeon removed 13 supernumerary teeth. So it's quite a lot. Uh, it's quite a lot for obstruction, right? Okay. So this time, I'm going to isolate my tooth number 21. So again, the same technique that I use, I start off with the eggshell view. I locate it. Now, that's where my tooth number 21, and then I placed my lines there. The next thing I will do is now follow the long axis of my tooth. For anteriors, it's pretty easy. Why? Because you just have to follow the canal. And just like in this one, I just reorient this view, and now we have a clear isolation of tooth number 21. Now you can see that the apex is not formed. It's in the middle of developing the far end of your middle third towards the apical third. So we're still looking for possibilities of orthodontic possibilities for this. So to see it clearly, so I take a snapshot of it, and then now we correlate. So again, this is your sinus already. This is your sinus. And this is your tooth number 2, 1. We correlate the bone density that we have on this one to this one. And what we see here is a very thin covering of bone. And of course, in ortho, we are uh, we are already considering managing it orthodontically by placing an attachment. However, uh, however, when we check the CBCTs again, this is the ANS already. This is the anterior nasal spine. This anterior nasal spine. The position of your incisor is quite high. And during surgery, it's the lips are very tense. The patient is complaining of a little bit of discomfort when they try to retract it, and we cannot have a very good control on the fluids, on the blood, and that's why we did not opt for attachment of the bracket. So with this one, it's still predictable in a sense that we know that there is a thin layer of bone covering it, and they just open it up, remove some bone so that we can allow it to passively erupt. So with those things, we can now look for possibilities of managing it orthodontically, since we cannot place an attachment on that location, on that high location. So a study by Da Costa and Xiang, when we look for possibilities, because we now see a full picture of the patient, it seems like it's our patient just without the skin and just without the gums, right? So it's our patient in its bone form, and it's like virtual reality. So we have here the case. So the approach is that since the root is on that situation in its development stage, it still has some it still has some uh, it still has some force to propel itself out into occlusion. So what we're going to do is we're going to place brackets and create space we open up a space for that 2, 1 to go out. So ideally, this should happen. So when the force to propel the tooth to erupt is exhausted, that's the time we will place the fixed attachment, and then we pull it down. So you see the difference in managing it. It gives us a very clear picture of our case, and it gives us a very clear picture on how we should approach it. Uh, we should be on the crossroads when we are deciding on the treatment possibilities, on the treatment plan, because it gives us a lot of room, a lot of options for the patient to decide. If we have the crossroads, if we are on the diagnostic crossroads, it's going to give us a hard time, because diagnostic crossroads gives us a whole lot of variety of treatment plans and a whole lot of level of uncertainty. So this one is a very nice application of the scan. So now we pull it down. So I think let's check for questions before I proceed to the next case. Okay. Okay. So I think we don't have questions. So let's proceed. So this is the next case. This case is it's more on the lower incisors, and we are looking at the possibility of torquing this one, and because of the position of this one. So we did the diagnostic parameters, and we came up with a solution to torque this one, because in the measurement of the SEF, it's not good. So when you say superimpositions, it's when your adjacent teeth or your adjacent structures covers up the area that you are managing. So this is the CBCT scan, and as you can see here, a very good application of CBCTs in ortho is on the alveolar boundaries, because you can now see your decisions on torquing it. So this is the image of the incisor in relation to the mandible. So now we're looking at some possibilities on how to torque it out, to torque the tooth. So is it possible? So this is a treatment planning software. So your CBCTs is not just for diagnosis. You can also use it for treatment planning. So this one, I just placed an incisor to simulate the initial position of this incisor. And as you can see on the registration on the three-dimensional image, you can see this small root tip going out. So torque should be done to avoid further damage. So to simulate how can we do the torque is like this one. So I use the software. It's easy. You just have to torque it. And as you can see, I'm going to play it back. If I play it back, what you will see here is this. You don't see now the root the root being prominent on this area because we changed the torque. So torquing is a possibility on this patient, and your CBCTs can help you on giving you a visual treatment objective, and that if you present this to your patient, of course, your confidence and their confidence on the treatment plan that you are proposing, on the treatment path you are going, will be good. So in ortho, we have this radiographic diagnostic parameters, right? So we have your panoramic and your lateral ceph. They always go hand in hand. And in some cases, we request a frontal ceph for some diagnostic objectives that we want to see, right? So we request radiographs depending on the diagnostic objectives that we want to achieve. And with these three radiographs, and because of superimpositions of the buccal, the lingual bones, and the tooth itself, this will be fairly limited in seeing these kinds of cases when you have fenestrations, right? So CBCTs, they eliminate the factor of superimposition. So now you can see here that you are losing a bone on this area, and of course this will definitely have an impact in your retention and your stability. So again, this is a subjective view. Let's try to look at it on the objective view. So this is another view, but it's not. It's based on the basic view. This is what we call a cross-section view. So your cross-section view is just a convenient combination of your sagittal and your coronal. So right now we are seeing here is the sagittal. It's a coronal view. So you have it here, and when we approach the anteriors, it becomes your sagittal. So you can see here that the bone is not correlating with the tooth, meaning this is the parallel between the 3D view and the cross-section view is good. Okay, you can see here that there is alveolar resorption on the labial, on the facial segment. So that's how we can check bone resorptions, especially on the buccal lingual or the facial lingual or facial palatal region. So let's go to the next case. And again, this is one of the first cases I've seen. And we want to know the cause of the pain of this tooth. So we are looking at the possibility that, and we are looking at eliminating of removing the buccal roots. We just want to see the palatal roots. And that's superimposition in the two-dimensional perspective. Your buccal roots, they superimpose your palatal roots, therefore giving you a very blurred vision on that area. And conventional two-dimensional techniques recommends that we use a mesial tube shift technique, or we use slab for us to localize the palatal root. And an easier way to do this is if we use a CBCT. So your CBCTs, I'm going to show you now how do we isolate a specific root. Okay, so it's possible in the CBCTs because there is no superimposition on this area. So you have, this is a different software. So I scan first. Of course, I go to the upper since I'm looking at the upper. And then I go to my target tooth, whether it's on the left or it's on the right. And then I place this one and follow the long axis again. I go to the canal and then I follow the long axis of that root. That way, we can isolate that root specifically. All right? So that's how we isolate. So the tip there is when you locate for your tooth, you locate first where is the arch, and then you go to the canal, and then you manipulate it following its long axis, and you will be good. You can have a good isolation. So this is the isolation of that case. So you can see here that there is a periapical ptosis on this area. And what could have caused this? Your CBCT, since the voxel size is smaller, it can go to a more detailed area, and you can see here that a possible cause and a more likely cause of this lesion right here is the tooth died, because there was a recurrent caries on this area, and bacteria traveled through the tooth tubules and invaded the pulp. And upon history taking, the restoration was 20 years ago. So of course, shrinkage and recurrence happened, and that's what we get. So definitely, this will be in root canal. We will do root canal treatment on this lesion. So let's go to this case, and before I proceed, so let's check if there are any questions. Let's check if there are any questions. Okay. Doctors, you can post your comments in the comments section. You can post your comments in the comment section below so that everyone can see. I received another PM of questions, so thank you, Doc. So the question was, sorry, I have to check. So the question is, how are you going to isolate curved roots? Okay, so how are we going to isolate curved roots? So your curved roots, since they are oriented in this position right here, and of course this will be another limitation, but what you can examine there is when you look at the axial view of it, seems like you're looking at the occlusal aspect, and you just have to scan it. So so you have I'll go back to that slide. So I'll go back to that slide. Um, so right here. So when you want to see your when you want to see the curvature of your canal, when you want to isolate, you want to visualize the curvature of your canal, what you can do is this. You have to scan it through the HL view, and what you can do there is, since you cannot see the whole canal per se, but you can see if there are any variation or anatomical morphology present. So you have to scan your HL view downwards, and that's you will examine. So this, like in this case again, from the orifice to the apex, I just scanned it down. I just found out three canals. Okay. So let's go to this. Let's go to this case, and again, so our issue here is how can we get a very clear visual of this case, and we have here your CBCTs in parallel to your occlusal photographs. So since we're going to deal first with the upper, and we're going to manage on the right side, here's what we see. Okay, so your third molars is positioned here. And when we look again on the 3D view, so this is the buccal aspect, and this is the lingual aspect. So your buccal aspect here shows that it appears to have 3 roots. Right? It appears that it has 3 roots already. But we have to be sure. And you can also visualize, and you can also see in this CBCT on this 3D view that your third molar influences your second molar to move and to supra-erupt buccally. Because when your third molars bumps that convexity on that area, it tends to bump your second molar and influences it to erupt and move buccally. So that could be this could and this could and this could cause your malocclusions if the third molars were not addressed. So I'm going to show you how we isolate your third molars. So we go first on the upper, this third molar in particular. So we go first on the upper, and now we go on the right side, and then we start isolating it. Again, just follow the long axis. And what we can see here in the detailed view of the sagittal perspective, we can see here there are 3 roots present, right? And now we scan that down from apical. So now we can see three roots at the end. So usually removal of the upper third molars is a fast procedure. It's a relatively faster procedure compared to the lower. However, some cases like this one, you might have a long, you might spend a lot of time, especially when taking care of that small root on the buccal. So here's a detailed view of this one. So like this, okay? So you have 3 roots, and as we scan here, we played around with it. You can see 3 roots as well, okay? So we just have to be careful on this one. And as of sinus approximation, it's really approximating your sinus. It's really approximating your sinus area. So we really need to be very careful when handling this type of patient. So we cannot be really confident on our skills. So this is this increases the difficulty. So now let's go to the lower. So the elements of your lower again is your mandibular canal. Where is it positioned? Where is it in relation to your tooth? Could be in front, could be behind, or it could be here. So your CBCTs for you to localize your mandibular canals, they allow you to do canal tracing. So your canal tracing, it traces your nerve so that you can clearly see and correlate it to your teeth. So I'm going to show you how to do canal tracing. So what we do here is we just have to look for the mental foramen, and all you have to do is like you're chasing jello or chasing jelly, and you just have to follow the path of your mandibular canal. Seems pretty hard, right? And that's your mandibular canal. So it's kind of advanced, but because softwares are developing and technology is constantly improving, there is now a simplified version of canal tracing. So this is from another software, and all you have to do is locate the mental foramen of the patient. So your mental foramen is usually located on the premolar area. So you just have to locate the mental foramen. Scroll it down in your HL view. You can see the line going down, and you can see this image going down. It goes to this part here. So that's your mental foramen. So that is your mental foramen already. So the next thing you'll do is, detect the nerve. And there is a guide here that allows you to detect the nerve. And you just have to find the mental foramen similar to this one here. You just have to click, and automatically your nerve is traced. So that's how easy nerve tracing is done now. Okay. So there was this manual and there is this automatic, but this automatic tracing, it still allows you to modify just in case there is some inaccuracies on the representation of your canal. So studies have shown as well that canal tracing is not applicable to all patients, because as the patient grows older, canals tend the visual the visual of your canal, the appearance of your canal, they tend to shrink as we age. So when you have patients who are in the geriatric area, geriatric region, canal tracing could be a little bit harder on your end. So I suggest on those cases, you have to do it manually. So now let's see if the canal tracing is correct. So those white dots, the dots that you see here, these are the areas that you can manipulate, meaning you can adjust these areas. So let's check if it follows the canal. So what we have to check is the black circle here. This represents your mandibular canal. Okay. All right. So as you can see here, there is a good follow-up. There's a good follow-through of the canal, following the tracing that the computer generated, and here. So let's see now how it correlates to our mandibular molars. So our question before is it in front, is it behind, or is it smack on the middle? And with our canal tracing here, it suggests that it's located on the lingual. So here, you can see here that your canal is located on the lingual. This is the apical region of your tooth, and this is the tracing of your canal. So it's located on the lingual. This is the buccal, and this is the lingual. Yeah. So let's see if there are any questions before we conclude. Okay. So again, if you have any question, you just have to comment it down below. So I have another question here. Is, how do I know if it's on the right, it's on the left, it's on the top, it's on the bottom? Your CBCT scans, your CBCT softwares, they have these indicators. Just for example, this one. What we see here is the right, R. So this is the right side of the patient. This is the right side of the patient. The letter B means buccal, and this is lingual. So definitely this is the buccal side, and that is the lingual side. So that's how orientation is set in your CBCT scans. Okay. So let's conclude this one. Some takeaway points is utilizing your CBCTs to achieve diagnostic objectives by utilizing the perspectives maximizes the diagnostic parameters that will allow consideration of various treatment options as well as avoid missed opportunities, thus significantly increase your treatment predictability. So your CBCTs, they they allow you to see all those diagnostic objectives that in your head uh, it allows you to see it face to face, and by utilizing its perspectives. And of course, a clear localization of questionable points in your diagnostic procedure will save you from misdiagnosis as well as further strengthening your patient's confidence in your treatment plan. So those are the takeaway points. Clear localization will definitely save you from misdiagnosis, and of course, confidence of your patient and your confidence to your treatment plans. Okay, so those are the takeaway points of this lecture. And to end this, dentistry is is a system. So we have diagnosis, we have treatment plan, and we have treatment delivery, right? And in digital dentistry, advancements allows us to make our work as accurate as possible, uh, delivering the most predictable outcome that we can offer. Of course, couple it with the good execution. And in digital dentistry, we try to cover all the grounds. We try to cover everything. So from an accurate diagnosis, your CBCTs, you will now convert it to an accurate treatment plan. So in digital dentistry, there are softwares that are merely for diagnosis, and there are softwares for just for treatment plans. But today, treatment planning softwares, they are now integrating diagnostic softwares so that you will have uh, easier easier time in manipulating it or in creating your treatment plans. So your treatment plans, since they are accurate right now, digital dentistry turns those accurate treatment plans to an accurate guide so that you can get an accurate treatment delivery. So let me give you an example. So you want to plan an implant. So your implants, your diagnosis, you assess your possible location of your implant. Now you're sure of where you're going to place your implant, you're going to plan it. You're going to simulate your implant placement. If it's good, what measurements should be done, what size of my implant should be used, and then you design your stent. You design your guides. How should I orient my drill? How should I orient everything? That's called fully guided. And with that one, the bridge from your treatment plan to an accurate treatment delivery are uh, your stents, are your surgical guides that allows you to just follow the guide, and it makes your treatment simpler, it makes your treatment easier, makes it highly predictable. So in digital dentistry, we call this sequence, we call these steps as digital workflow. And by with the follow through of an accurate diagnosis to an accurate treatment plan to an accurate treatment delivery, your digital workflow will influence a predictable treatment outcome. So that is and CBCTs, again, doctors, CBCTs are the fundamental diagnostic parameter of your digital dentistry. So let's see if we have questions. Okay. So Okay. So the end of our poll. I'm going to update everyone to the end of our poll. Uh, our audience today. So the crowd is more quite familiar, and we have audiences who use CBCTs routinely, and we have doctors that has CBCTs but they don't know how to manipulate. And I mean the secret of a good uh, the secret of an ease of manipulation is to know the perspectives. And for those who are not familiar, I hope this lecture gave you a good recognition of seeing your cases in virtual reality. And to those who are quite familiar, I hope this lecture further improved your further improved your urge to do three-dimensional imaging techniques and to do this diagnostic parameter to achieve some diagnostic objectives. So I'm going to send out another poll, but this one is before everyone leaves. So I'm going to publish another poll. So I just want to know what you think. And again, I'm Dr. Paolo Pangilinan, and I'm going to invite everyone that on Saturday we're going to have two webinars in the morning. It's a very nice discussion, a very nice exchange of ideas between Dr. Jet, Dr. Pau, and Dr. RJ Dulay. It's all about COVID-19, and we really hope you could join us there, as well as episode 4 of Botch this Saturday. It's as we further go to this webinar series, the cases becomes more interesting. So I don't want you guys to miss out. So with that, okay. So with that, I thank you for joining me, and we hope you guys are safe in this quarantine period.